Hello, everybody. Welcome back to the show, Science Dispatch Podcast, your weekly source for interesting science news and observation and stupid jokes on occasion. My name is Cameron English, joined again by Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, what's going on? Nice to see you again.
It's a beautiful day in the neighborhood for a change. Spring has come to the Northeast. It gives me great hope. And we're entering the St. Patrick's Day weekend.
Okay. So lots of green beer in your future. Is that what you're trying to say?
I'm not so much a green beer as I would be very happy with a corned beef sandwich.
There you go. You can't ever go wrong with corned beef, I don't think. It's a pretty tasty treat. We do have, unfortunately, a very difficult topic to discuss today. This is a story by our colleague, Dr. Josh Bloom, who's unable to join us. But the story is called Death Without Pain, an interview with Lori Engel. And this is tough. This is tough trigger warning for everybody out there. We'll get into the details, Chuck. But the basis of this is that Lori is a terminal cancer patient. I forget which cancer she had, but it metastasized to her spine, and she's not long for this world, unfortunately. I'm sorry to say that. But Josh interviewed her and goes through the hoops that she has to jump through. She's in hospice care. She's end-of-life care. But she has to jump all kinds of ridiculous hurdles to get access to pain treatment, right? Because it's primarily opioids. And as we've discussed on the show, there's all kinds of hysteria and confusion and awful policy in the United States around this topic. And so even when you are in excruciating pain from a disease that your doctors know is going to take your life, it's still hard to get medicine just to live with, a reasonable amount of comfort until it's time to kick off this mortal coil. So Chuck, I mean, as a physician, I'm sure you've seen all sorts of stories like this. What was your take on her experience?
Well, first of all, the story is both horrific and I think, unfortunately, becoming more typical. She originally developed some chronic injuries 25, 30 years ago for which she elected to treat them with pain medications rather than surgical interventions or other medical treatments. So that was fine. I think that there's nothing wrong with making that choice. And when she made the choice, pain was still the fifth vital sign. Very important that we all get on board with that. And the reason for pain becoming such an important issue was the findings that ironically, in patients in hospice, doctors were holding back on narcotics because they were afraid it would hasten their death. So they did a number of studies and found that, in fact, that the judicious and appropriate management of pain with a variety of medications, primarily opioids, but laid out in various ways, did not accelerate anybody's demise, and so pain became the fifth vital sign. So her choice of pain medicines in that time frame makes perfectly good sense. Over the course of time, while her pain needs continued, and as did her drug regimens, the culture has shifted. In fact, the physicians who are responsible opioid prescribing, Dr. Ballantyne, their vice president and anesthesiologist, was the one to say that she was very hesitant to give people that were in hospice opioids because she was afraid it would leave them addicted. So if you can wrap your eyes or your head around that one, that's good. I just don't see the advantage there. I think that it's important to draw a distinction between judicious use of opioids and anything goes opioids. And especially as one becomes more frail towards the end of their lives, you may need to cut back on the doses or not, depending on how those drugs affect people's respiratory depression and other functions. But that's more of a inside baseball medical problem that we needn't address. But her problem really is emblematic of what's gone on. So she reached the point when she was found to have a metastatic cancer. It's the kind of cancer that can be treated by a bone marrow transplant, but in order to do the bone marrow transplant, you need to spend upwards to 6 months in a inpatient setting while the marrow that they've destroyed has a chance to recover with the marrow that they've transplanted. It's not a simple one and done kind of treatment. So she opted not to have that treatment, and she opted to have that not have that treatment. Additionally, because she saw from what her reading in the literature was is that there was not a good long-term prognosis. So for the quality of her life, she elected to enter what is described as home hospice. She wasn't institutionalized. She remained at home, but her care was transferred to a hospice physician, and the agreement was struck that should she have a event that would require an ambulance and life support, that she would not choose to do that. That's really the basics of hospice. And at that point, she ran into a modern medical system where the office of her oncologist referred her to a local hospice service. And at that point, the wheels came off the wagon, as it were. The intake nurse did a chart review of her medications and then passed that along to the supervising physician, who also did not examine her and did not actually speak with her, but rewrote her medications to conform to what evidently was hospice policy at this particular hospice program. What I found unbelievable was the fact that she was placed on medicines that she had indicated to the nurse she could not take because she had had bad reactions to them in the past. I mean, it's beyond my understanding as an old doctor how a physician, knowing that a medicine was bad for you, would insist that you continue to take it. There's a certain inflexibility there that's just, even to a surgical mind, not understandable. And that problem continued for the next week or 10 days until she took it upon her own to find herself another hospice organization. And once she found another hospice organization, they were more than willing to deal with the pain regimen that had been working for her for 27 years, for which she had been fully functional. And with that, at least the issues of pain management were sufficiently addressed.
The part of this that I find so infuriating is the fact that she, as you just said, she was using these medicines. OxyContin, I think, was the primary one. She was using these for upwards of 3 decades, and they were well tolerated. Yes. And I think that experience has been shown pretty consistently in the literature, that when you have people that need drugs like this for pain management for a real condition, they handle it well. Now some of them do develop physical dependence, but that's different than addiction. You know, it's not like you put these people on medicine and then they go out and they start wreaking havoc around their town, lighting things on fire and having sex with everyone that they, you know what I mean? Like it's not like reefer madness. It's like they're in pain, and this just allows them to function without suffering constantly.
Right. So there's other 2 things in there. One is that they're taking the medicine so that they can function at a level closer appropriating normal, whatever you wish to define normal as. Now, I think that distinction between dependence and addiction, when you get right down to it, addiction is the aberrant behavior that allows you to continue your dependence. Okay? So if you're getting prescribed medicines, you have no reason for aberrant behavior. You just have to go and pick them up, or they're delivered by the U.S. Postal Service from the mail order. That piece is gone. If you actually have access to your pain meds, there's no chance of becoming addicted. even though you already are physically dependent. But some of that's a little bit of it wordplay. But once you take away the meds, then you made them addicted, because now they have to run around and find some kind of substitute. And she describes very much the painful process of trying to find a substitute in an environment that less and less welcomes the use of opioids for any reason. I mean, I can tell you, having had 3 major operations over the course of the last 3 years, they did offer me some opioids after my open heart surgery, but everything else was have some Tylenol, and so that's just another layer of craziness to the story.
I've mentioned this before, Chuck, and I know a lot of people in the pain patient community have talked about it, but while this opioid clampdown or prohibition, whatever you want to call it, while this is happening in medicine, you have a very influential movement of harm reduction advocates who have been pretty good, at least in some parts of the country, of getting publicly funded programs that will allow people who are addicted to street drugs to have a safe place to do them in a way to reduce their risk of overdose or their risk of infectious or sexually transmitted diseases, all these things. And what I don't understand, and not to knock harm reduction, because I think it does have some value in certain circumstances, but what I don't understand is why we can't show the same level of sympathy for pain patients like Lori in this case. It's like we don't want the heroin addict to overdose on the street, and so we're going to bend over backwards in some cases to look out for that person. But this woman who has a bowed leg and her choice was, cut off your leg or take these drugs. Well, we changed our minds. You can't have these because these are really bad for you, and we don't want you to be addicted. It's like there's an insanity here, and there's competing interests involved. Obviously, that complicates it. But as a society, I just can't wrap my head around why we can't find some middle ground that makes sense for.
I think that it has to do with the problem of intentionality, and whether when you look at the individual, whether you think that this is their fault or not. Certainly, we've seen this with the whole obesity issue. We can shame fat people when it's their fault. That's why it has to be a disease, because then it can't be their fault, and they can't be shamed anymore. And I think that it's similar when you start talking about chronic pain, because when you see the people that have chronic pain, there is, I think, unfortunately, a tendency to place them in the category of other, and they're there because they did something wrong. I guess it's a variation on that sense of luck and hard work. That anything good that I do comes from my hard work. Anything good that you do comes from your good luck. And that maybe that's the reverse when you talk about bad luck. If I have bad luck, it's just because it's bad luck, and if you have bad luck, it's because it's something you did.
Yeah, sucks to be you, I guess, is the.
There we go. That's certainly a succinct motto.
Yeah, that's the summary of it. In closing here, I'm always struck when this topic comes up by something our colleague Dr. Josh Bloom, who conducted this interview, said. First time I ever talked to him on a podcast I was doing years ago about opioids and the fentanyl epidemic and all this stuff, and he said, this could happen to anybody. All it would take is a really bad car accident that crushes both your knees, like a real critical injury that you didn't deserve, you didn't do anything to earn, as we were just alluding to. And then you are in this situation potentially for the rest of your life because there's a handful of dipshit tort lawyers and activists who think they know what's good for you. And you're just going to suffer for that. And I wish I wish this could go away, but I wish there was a way to get that message out to people so they understand that they're connected to this. This could be your mom. This could be your child. This could be you. And, something has to change, I guess, is what I'm getting at here.
Yes. I think you're 100% correct. We don't, Maybe one of the ways we try and distance ourselves from this is by saying it's them and it can't happen to me. I think that may be part of how we cope with it. And again, in a shameless moment of things that are going on the website today, there was an article in the New York Times talking about whether we should be talking about drug overdoses as overdose or poisonings. And it's the same conversation about the attribution of blame. If somebody is poisoned and dies, and in a lot of cases where you buy a pill and you wind up getting fentanyl when you thought you were going to get something else, it is in fact a poisoning. That shifts the blame and responsibility in part to other people, and I think that's not an uncommon reaction. I think that the problem here is that in order to make ourselves feel safer, it's easier to distance ourselves from these individuals and say it's something they did. And so it ain't going to happen to me because I'm smarter and wiser than that, and I don't have that happen to me. The other thing I would just say in passing, just because I'm reading at the moment, is Demon Copperhead, which is the Appalachian version of David Copperfield that came out a year or two ago. And the character, who has had a horrible life up to now and has become a big-time high school football player, just screwed up his knee and is being given Oxycontin. So you know where we're headed in this particular story. It is not going to be going well for the next several months for Demon as he deals with this particular demon.
All-American boy just living his life, and then Purdue comes in and hooks him on their demon drug, and his life is over. It's a real original story. I'm really glad that author came up with it. It's never been told before.
Well, I mean, the beautiful thing about it is Charles Dickens told the story 100 years previously. He just altered the facts a little differently.
Yeah, take someone.
This is the Appalachian version. And by the way, she writes beautifully. If you're looking for something to read, it is a great and easy read. It's a good book.
Very good. All right. Well, there you go. See, we tell you about science, and then you get book recommendations. Stop by your nearest Barnes and Noble and pick up a copy of that book. But we're going to land the plane. Thank you all for joining us. As always, you can follow us on social media. The organization is at ACSH.org on X. I am at CamJEnglish, and the website is acsh.org. Reach out to Chuck there. Shoot him an email. And check out all the articles, including this one that we just discussed. So once again, the title is Death Without Pain, an interview with Lori Engel. Tough read, just a heads up, but an important read. So with that, thank you so much, and we will see you next time.